See the slides okay?
Yes.
Okay, great. Thank you for the introduction and thanks for having me here.
No,
So
you're
I
welcome.
have a presentation prepared that will take me about 35 minutes to get through, and then we can go through questions at the end. So title of the presentation is The Approaches to Treatment and Management of Complex Patients with Concurrent Mental Health, Chronic Pain, and Substance Use Disorders. And I'm guessing many of you are here today because you have patients or clients who have one or all of these conditions together. In terms of my disclosures, I have received grant funding from Health Canada's Substance Use and Addictions Program, as well as Indigenous Services Canada, and I receive an ongoing honorarium as a chapter editor for the Clinical Handbook of Psychotropic Drugs. In terms of my perspective as a clinical pharmacist, of course, medications are going to be a big piece that frames my position in terms of providing this presentation, but we will talk about other aspects of patients' care. Additionally, I have most of my clinical experience on the inpatient side, especially psychiatry focused. But over the last 3 and a bit years, working with the USAF's chronic pain clinic team, I have some outpatient chronic pain experience, and then the research side around that. And then, of course, as my position is based here at the university, experience teaching undergraduate and graduate level students. So what I hope for us to accomplish during my presentation, we'll discuss some of the personal and community impacts of concurrent issues around pain, mental health, and substance use disorders. I'll describe some techniques in terms of screening for those conditions. We'll go through a fictional patient case to help us try and have some discussion and thought around treatment and management of individuals living with concurrent pain, mental health, and substance use conditions. And then I'll provide some evidence-based resources that perhaps you can use in your practice. So when we're talking about chronic non-cancer pain, it's really important to lay the foundation here that medications are only one piece of the picture. There's so much that needs to go into the mindfulness strategies for chronic pain management, as well as movement strategies to really empower patients to move towards appropriate care for the chronic non-cancer pain. As a pharmacist, though, my lens generally is around the medications. So that's why a lot of this conversation today will focus on meds, but I do recognize they're only one piece of the puzzle. So just to frame the context of these overlapping conditions, up to 75% of individuals living with chronic pain will have a psychiatric comorbidity. And it may even be higher given the challenges of diagnosing patients. In terms of them seeking care, they might not have sought care for diagnosis and other related concerns around that. Additionally, of people living with a diagnosed mental health or psychiatric condition, 1 in 2 people will also experience a substance use disorder in their lifetime. So a lot of comorbidity there. And then out of people who are prescribed chronic opioids for chronic pain, 1 or 2 of those people out of 20 people will go on to develop or have a history of having developed an opioid use disorder. So again, really highlighting there's a lot of overlap between chronic pain, mental health conditions, and substance use disorders. So let's touch a bit on my first objective around the personal and community impact of these overlapping conditions. Again, a different Venn diagram here highlighting how it's going to be very common that in our practices, we'll see patients living with chronic non-cancer pain who also have mental health conditions, who may also have a substance use disorder. And I'll highlight in some subsequent slides that we may not know what condition came first. But what we do know is that someone at the middle of this Venn diagram, they're going to be probably the most challenging patients or clients that we care for. In terms of mental health concerns, what specific conditions are we talking about coexisting with chronic non-cancer pain? For sure, depression and anxiety are going to be at the top of the list, but other conditions such as insomnia and even some severe and persistent mental illnesses such as bipolar disorder and schizophrenia can co-occur, but predominantly in this area, we're talking about issues around mood and sleep. And like I mentioned earlier, it's not uncommon that these mental health conditions have gone undiagnosed. Perhaps the chronic pain condition limits the person accessing care. Perhaps they're not disclosing what they're experiencing to healthcare professionals. There can be a lot of pieces of the puzzle that confound them not getting a diagnosis. And unfortunately, when someone goes undiagnosed with their mental health condition, this can lead to ineffective or impossible to treat chronic pain because we know that things like depression and anxiety, they heighten the pain that people experience. They reduce the person's quality of life and can help them experience more somatic symptoms of their pain. So we really need to get the mental health concerns under control to help dial down the ways in which they experience their pain. In terms of substance use disorders, we know that chronic pain is associated with a lot of emotional distress. And through that distress, there's disruption and dysregulation in the brain's circulatory, especially around reward, which can lead to people leaning on substances to help them cope. And we know this as there are high rates of opioid misuse and dependence in patients living with chronic non-cancer pain. And this really highlights the need that if we are caring for someone with chronic pain, we need to have effective screening strategies and ongoing monitoring to effectively monitor for safe and effective opioid use, as well as other substances that could be prone to misuse. And then in terms of the prevalence of chronic non-cancer pain, I'm sure many of you or all of you on this call are familiar that it does impact 1 in 5 Canadians. It's defined as pain persisting beyond 3 months. And it's not just a physical pain. It affects people psychologically, spiritually. There are social factors, and it's really a complex biopsychosocial phenomenon that people experience. And through that, we can't just fix it with medications that work on the biological aspect. There really needs to be an integrated approach that addresses the human being experiencing this from all aspects, including psychological, spiritual, the physical piece, of course, medication being one piece of that puzzle. And often we'll come across patients, and I know at the USAS Chronic Pain Clinic here, we have a number of people who they've been experiencing their pain, they've been on their pain journey for years. And we might not know if it was their chronic pain that started first, that led to them being on chronic opioids, that led to depression and anxiety, or maybe it's someone who initially they were really struggling with mood throughout their life and somehow they ended up on chronic opioids, maybe initially starting from some recreational use or chemical coping that then led to maybe an accident, fall, car accident that led to some chronic pain. And it can become a vicious cycle where someone, we might not be able to pinpoint where they've started, but they often will fluctuate between different aspects here. And if we don't manage all conditions, it can really be overall detrimental to reduced quality of life and functional capacity for that individual. I pulled this quote from the Canadian Pain Task Force. They have an excellent summary of resource and evidence around chronic pain management, but I really like that they've built in quotes from people living with chronic pain. So I'll just pause for a few seconds for you to read through this. So when I was reading through the Canadian Pain Task Force and I saw this quote provided by someone living with chronic pain, I thought it did an excellent job of highlighting some of the concerns that people living with pain experience in terms of trying to seek help. And I think this does a good representation not only of chronic non-cancer pain, but also maybe some underlying mental health concerns or substance use disorders that people might be fearful or self shaming in terms of seeking help for. And if we can empower ourselves as healthcare providers to understand and seek to understand where people are meeting us from and trying to understand the different conditions, history, trauma that they're experiencing, it can help us to care for them. When it comes to medication use for chronic non-cancer pain, that's on the right-hand side of this diagram, there can be a spectrum. We're going to meet patients who are on meds for chronic non-cancer pain. They're adherent, they're following everything we advise them to do. And it can go to the far right of this spectrum where they do develop a substance use disorder. And perhaps that substance is the prescribed opioid they have. And there's going to be some middle ground where maybe they don't check all the boxes of the opioid use disorder diagnosis, but there is some problematic use they're experiencing. And I will provide some screening tools that we can use to help us to identify those patients. And I like this diagram. I took this picture from the Australian guidelines around opioid management to help us understand that, yes, we will see patients with pain on opioids, but there are also going to be non-medical users who will develop similar looking opioid use disorders, but their care might be a bit different if they don't have an underlying chronic non-cancer pain. So again, it's all on a spectrum. And with all of this background information I've provided, I think there's such a need in our healthcare system for coordinated and integrated care. So I myself, as a pharmacist, have a physician I can work with, a social worker, a physical therapist, that we're all working together. We're communicating with the patient's family physician. And I think there are movements and strides being made in terms of our healthcare system, but I think this can be even more improved to help us overall holistically care for people living with chronic non-cancer pain. Now shifting gears a little bit more to focus on why we're talking a lot about opioids and their related harms around chronic non-cancer pain. We know, especially if someone has a substance use disorder co-occurring or mental health disorder, they're often going to be on other CNS depressing medications. And an opioid plus any of these medications listed on the slide are going to increase the risk of an opioid overdose or opioid toxicity episode. So it's not uncommon to see someone on, say, hydromorphone as their opioid. They're co-prescribed some lorazepam for anxiety. They're on gabapentin for their pain. All of those pieces added together increase the risk of opioid toxicity for that patient. And there's good data to show that, unfortunately, there are a lot of harms being seen with opioids co-prescribed with CNS depressants. Together, that CNS depression can manifest as sedation, impaired cognition, slowed response time, respiratory depression, and ultimately death. And it's really this polysubstance use is the most consistent predictor of problematic opioid use and associated overdose and death. So when it comes to patients with these comorbid conditions, it's really helping us as healthcare providers help the patient by finding an effective balance of treating their chronic pain, psychiatric, and substance use disorders with trying not to contribute to excess CNS depression. So in a few slides, we'll talk about a patient, George, and you'll see how I've tried to optimize his medications in a way that removes this excess CNS depression while trying to find an optimal treatment for his comorbid conditions. So I'm sure many of you have seen this slide or similar data from the Health Canada website. They have a really good info base summarizing, unfortunately, the number of deaths we've seen in our country. So the complete data from 2022 wasn't published when I put this presentation together about a month ago. But the year prior, in 2021, we know we lost close to 8,000 people in Canada from an opioid toxicity. And we know that about 11% of these were accidental deaths that involved a pharmaceutical grade opioid. And in Saskatchewan, we have not been spared from this. This is data from our coroner's service that shows the number of people passing away due to drug toxicity deaths between 2016 and 2022. Additional statistics, I won't belabor these points more. These data are here as reference in terms of highlighting how there is data to show that when benzos, gabapentinoids are combined with opioids, there's a much higher risk of opioid toxicity episodes. And opioids plus any CNS depressant, there's documented episodes of increased injuries like motor vehicle accidents, falls and fractures, other substance use disorders. So an array of risks in terms of opioids when combined with other CNS depressants. And Health Canada has put out alerts, safety warnings around this. So caution around gabapentinoids when combined with opioids, as well as benzodiazepines, warnings around combining them with opioids. So what can we do, and how can we as healthcare providers screen for patients who might be at risk of some of these harms? So in terms of screening for depression, you might be familiar with the PHQ-9 Patient Health Questionnaire 9-question scale that helps to screen for depression. It's not going to be an absolute in terms of diagnosing patients, but it can help to screen for, is someone possibly at risk of depression? And it can be used to gauge kind of severity, but of course it needs to be combined with a physician's assessment and a clinical diagnosis. So this tool can be helpful. You can give it to patients and get them to self-fill out. If you don't have time for them to do the 9 questions, there is an abbreviated quick screen, the PHQ-2 for primary care. And if a patient screens positive as a score of 3 or more, this could be indicative that they are experiencing depression and that they should be referred to a healthcare provider for diagnosis. In terms of anxiety screening, the GAD-7 tool, again, you can give it to a patient for them to fill out. And if they do score even more than 3 on this tool, I would encourage you to refer them for appropriate diagnosis. In terms of tools for alcohol use disorder screening, we know that alcohol-related harms are a big problem in our country. Our province of Saskatchewan has some of the highest risk of alcohol use disorders. And there are a number of tools that can be used to screen for it, but often they're not effectively used in practice. And in terms of missing screening for alcohol use disorder, we also, as a healthcare profession, often miss treating patients for alcohol use disorder. So there's data from the US and Europe that less than 10% of people with alcohol use disorder are on effective treatment. And I've seen data from Ontario that show even less than that. I think it was a study in Ontario that looked at patients with a diagnosed alcohol use disorder, whether or not they were on guideline treatment for their alcohol use disorder, and less than 1% were. So I think there's lots of room for improvement in terms of screening for alcohol problematic use and getting people on effective treatment. Whoops. So what tools could you use to screen for alcohol use disorder? Well, there's this simplified alcohol use disorder screen where simply you ask people, do you sometimes drink beer, wine, or other alcoholic beverages? And if they say yes, then you could go into asking around quantity. There's differences there based on men or women. And then if they do screen positive, you could go into the number of heavy drinking days in the past year. So if they answer yes to the first question and then yes to either the male or female version, you could identify this as possible problematic use, and they should be referred to a provider for further diagnosis. If the person is hard to engage with, they don't want to answer those questions when you ask them, the audit tool is a patient self-report tool that might be helpful for them to fill out on their own, and then you could review the results after they fill it out. So that's another screening tool for alcohol use disorder. Other screening tools we should use, I guess just a general awareness, observing our patients or clients, understanding the medications we give them or other substances they are using. Are they altering the route? So if we give someone prescribed oral opioids for treatment of pain and we learn that they're snorting or injecting them, that's concerning. If they have history of perhaps recurrently losing their medication, they have a pattern of stating they lost it. That could show some drug-seeking behaviors. Their functional status, has it started to deteriorate? Loss of job, problematic relationships. All of those factors can tell us a lot about how patients are doing and could help us to identify issues that we can hopefully get them on the right track with appropriate treatment and care if we're identifying concerning issues earlier on. In terms of screening for aberrant drug behaviors, specifically around opioid use disorder, there's no one risk assessment tool that can guarantee accurate risk for one patient. If you go into the literature and try to look through this, 3 common scales that will come up would be the ones listed here. So the COM tool, the current opioid misuse measure, it's a 17-point tool. It's used for people on long-term opioid therapy. It is a bit long though, so it might not be practical to be done in practice. The opioid risk tool, it can be helpful even before you prescribe opioids to a patient. If you're weighing the pros and cons, you're not sure if this is someone that could be predisposed to drug use risks. This can help in that setting. And then the POMI, or Prescription Opioid Misuse Index, it's a very brief tool. It's one that we often use at the USAS Chronic Pain Clinic to help identify potentially problematic use patterns around prescription opioids. And I have it listed here on this slide. It's 6 questions, yes or no. And if the patient scores more than 2 overall yeses, this could be a sign that there is potentially some problematic opioid use underlying their condition and that they should be sent for appropriate diagnostic screening. And then the other piece, observing for patients, the 4 C's of addiction, as a reminder of what those are, would be compulsion to use, impaired control over the behavior, continued use despite negative consequences, and then cravings for that substance. Screening can also extend to screening for opioid overdose risk factors. So I mentioned earlier on in the background part of the presentation, there are a lot of risk factors that can add to opioid overdose risk. So combining with other CNS depressants, we know, and we could spend a lot of time talking about amount of opioid that the patient is on. So more than 90 milligrams of morphine per day is a risk. Advanced age of patients, so those over the age of 65 or with respiratory or hepatic dysfunction, history of overdose, injection drug use, all of these combined together increase the risk of opioid overdose risk in a patient. So how do we apply some of this information to a case? And we'll do that by talking through a composite case. So this is patient George, and he's a composite of a number of patients I've met through my practice. So he's a 66-year-old gentleman. He's referred to the USAS Chronic Pain Clinic by his family physician for management of chronic pain, specifically musculoskeletal pain and neuropathic pain. So we learned that George was a welder for 30 years, and he was forced to quit early due to back pain. He reports mainly right-sided body pain and right-sided sciatic nerve pain. He also has dull, achy pain from his back to his knees and occasional sharp pain in his left knee. He says he often has tingling in his fingers and hands, and he has no feeling in his fingertips. He has a hard time sitting for prolonged periods of time, and he says he's really coping day by day. Often throughout the day, he struggles to stay awake and often nods off. So his goal when he comes to us is to get through the day where pain is manageable. In terms of additional past medical history, so he's lived with this chronic low back pain for 20 years. He has degenerative disc disease. He's had 3 previous surgeries, including a spinal stimulator inserted 6 years ago. He's trialed morphine for 15 years, oxycodone for 5 years at increasing doses. He has a substance use history of drinking 6 to 12 beers per day. When he's out with his friends, he might drink 10 plus whiskeys. He previously smoked, but quit 30 years ago. His comorbid conditions include this bilateral osteoarthritis of his knees, major depressive disorder, type 2 diabetes, polyneuropathy secondary to type 2 diabetes. He has coronary artery disease, and he had an MI in 2014 with a bare metal stent placed. He has GERD and COPD. When we look in eHealth, we see that he's had a recent urine drug screen, and it was positive for lorazepam, oxycodone, and tricyclic antidepressants. All of his lab work is within normal limits. So his current medication list, I won't read through all of them, but the ones for us to focus on, he's on oxycodone controlled release, plus immediate release, lorazepam, amitriptyline, and pregabalin. And overall, his daily morphine equivalents are around 120 to 150 milligrams. So when we think about the overdose risk factors, our dear patient George has a number of risk factors that place him at risk of opioid overdose. He also has a lot of risk of opioid-induced harms. So we learned from him he has trouble sleeping. He's often woken up by abrupt need to gasp for breath. So possibly some sleep apnea, which we know are associated with long-term opioid use. He tells us that his pain has been increasing over the years despite increasing oxycodone dose. So maybe some opioid-induced hyperalgesia. He tells us his depression diagnosis came after his pain diagnosis. We know opioids can contribute to that. And we learned that he has been taking more of his as-needed oxycodone than prescribed. So possibly some underlying opioid use disorder as well. So it would take a lot of time, and we only have a short period of time today to discuss this, but probably a lot of work with medical social workers, maybe counselors. There might be a need to engage with psychiatry here to understand George's depression, to understand his goals and help him understand his chronic pain. Probably a lot of education would be required to help work on his care holistically. And I think one of the first things we might need to do is to address his underlying alcohol use, as it sounds like that's something he's chemically coping with. So certainly George is hitting a number of the points listed here in terms of what could be a vicious cycle in terms of decreasing his quality of life and functional capacity. So where would we start? Again, thinking about the mind, medication, and movement, lots of role for the non-medication strategies. But as a pharmacist, I'm here highlighting the medication aspect. So in terms of chronic low back pain, and his low back pain is his biggest problem, the RX Files has excellent summaries around this, where generally opioids are not recommended as harms exceed benefit. So we have data to suggest that the opioid he's on is not evidence-based. We can't just suddenly take it away. There would need to be a lot of education around this and appropriate planning in terms of how we manage the opioid. Some information that has been highlighted in terms of when to consider opioid tapering. If we see lack of improvement in pain or function, which George has had, he's on more than 90 milligrams of morphine a day, which we know exceeds the general risk versus benefit. There's some possible non-adherence to treatment plan, signs of problematic use. He's combining with alcohol. He's using more of his PRNs. There's definitely some serious opioid adverse effects that could be playing a role. At this point, he's not requesting it, but perhaps we can work on stabilizing some of the other psychosocial components, his depression and alcohol use disorder, provide him with education, and hopefully bring him around on the stages of change where he's open to exploring tapering from his opioid. There are a number of strategies that can be taken upon to taper someone from opioids. We don't have time to get into that today, but I will say someone like George, he's been on opioids for years. We're not going to suddenly take it away. It's probably going to be more a slow and gradual taper, which might include rotating to an alternate opioid or considering a transition to opioid agonist therapy, especially if that diagnosis of opioid use disorder is made. You might be saying, well, I've read recent publications that say opioid tapering is harmful. Yes, this is a paper that was published in the JAMA Open journal. that did show that patients with long-term opioid therapy, if they were abruptly discontinued off their opioid, there was increase in mental health concerns and suicide rates. But I will say these were very abruptly tapered patients. They didn't have a lot of psychosocial supports. And there are other data that suggest, and RX Files has a good summary of this, of 40 different studies that looked at opioid tapering in someone like George. And for most of the patients, if they were supported in terms of psychosocial strategies and other pain management strategies, the opioid tapering was associated with improved pain and function and quality of life outcomes. So, as a very brief glimpse into where George's medications could potentially end up, and I would have to say this might be over months or years, there could be a transition from his oxycodone over to buprenorphine naloxone or Suboxone to target his chronic pain, his opioid-induced hyperalgesia, opioid use disorder, if that's diagnosed. And buprenorphine brings a safer profile in terms of opioids compared to full opioid agonists. His lorazepam, hopefully we're able to work on coming off of that, as it's not indicated for long-term anxiety. It has risks of worsening depression, increased opioid toxicity. If we're able to control his anxiety, depression with a different antidepressant, for example, changing his amitriptyline over to duloxetine, hopefully we could work on coming off the lorazepam. Gabapentin does have evidence for pain and alcohol use disorder, so it could be a possible option. And then perhaps there is a role for acetaminophen as long as his liver function remains stable and he works on coming off of the alcohol use. So again, this is going to take months, possibly years, to come up with a safer med profile, and definitely needs to be in conjunction with non-pharm strategies for chronic pain, mental health, and his substance use conditions. Just a brief note on naloxone, and I hope all of you leave this talk thinking about naloxone, not only for patients with opioid use disorder, but also for patients living with chronic pain. There's good data to suggest that anyone with opioids in their house has a naloxone kit, and especially if we're adjusting opioids, we're switching to another one, we're tapering, there's going to be loss of tolerance, there's going to be increased risk of overdose. And naloxone actually has a really good number needed to treat, meaning that for every 10 kits used, 1 overdose death is prevented. And we don't have very many medications that are this effective. So definitely something to try to integrate into your practice. And this is just a highlight. The USAS Chronic Pain Clinic has a naloxone education handout. It's available free on our website that tries to remove some of the stigma around naloxone. I think a lot of the resources out there are geared towards people who misuse opioids in the opioid use disorder context. And this one is more, I'd say, medical in a way, focused more just on naloxone without any injection drug referring information. So there for you as a resource. And then lastly, just a few other resources you might find helpful while working in this area. The group out of Alberta that creates the peer guidelines, they have a really helpful, very easy to read through document on opioid use disorder, as well as chronic back pain treatment, osteoarthritis treatment. They do a great job of summarizing evidence for these treatments. Our team has created an excellent toolkit in terms of resources to help patients self-manage their pain, lots of educational materials, resources available in our province. RX Files, I can't give them enough kudos in terms of summarizing literature around medication treatments for chronic pain. And I know they're working on their next edition of this chronic pain booklet. They also have a number of patient information booklets available. These are available free to Saskatchewan healthcare providers if you want to have these in your clinic for patients to help boost their knowledge on these different topics. And they're also available on the RX Files website. Different psychotropic drug resources that can be helpful. The Stalls textbook, it's pretty deep into the psychopharmacology, but if you want a refresher on that, That's a good resource. A more practical clinical-based tool would be the Handbook of Psychotropic Drugs. Lots of good information there on different psych drugs and very practical in terms of information there. And then this online resource, SwitchRx, is a good tool in terms of thinking about switching between antipsychotics, antidepressants. So with that, I know I covered a lot of information, but I hope you leave thinking about how it's very common we'll encounter patients with mental health, pain, and substance use disorders. Ideally, if we can have an integrated approach to care. When it comes to the medication aspects, opioids are often in these patients combined with a number of CNS depressing medications. And if we can work to streamline meds as much as possible to reduce polypharmacy and CNS depressant effects, we can do a lot in terms of helping to benefit our patients. But often these changes need to be done slowly to avoid withdrawal and rebound effects. So thank you for your attention. And I think we have a few minutes left for questions.
Thank you so much, Dr. Halpape. That was an excellent presentation. So now I'm going to stop the recording and we will be taking the questions.